Hello and welcome to the NeuroNoodle Network Podcast News and Notes Edition. I'm Pete Jansons, and alongside me will be Anthony Ramos. He's a passionate enthusiast and connoisseur of technology content in the realms of mental health and well-being. In our show, we delve into the latest news, innovative research, and emerging trends in neuroscience and mental health. Anthony brings a fresh perspective as a dedicated follower and fan, sharing insights and reflections on our past NeuroNoodle Podcast episodes, as well as his take on the latest developments in the field. Whether you're a professional, a student, or simply someone fascinated by mental health and neuroscience, join us as we explore these topics in a format that's informative, engaging, and accessible to all. So without further ado, let's dive into what's new and noteworthy in the world of mental health and neuroscience and just plain old technology. Let's hear Anthony's thoughts on our previous discussions and current trends. The NeuroNoodle Podcast is supported by listeners and businesses just like you. I can hear you.
Oh, perfect. All right. This is it's been a while since I've done this. Thanks for having me on. Sorry it took me a little bit to be comfortable with the idea.
Yeah, no problem, man.
I think you said, oh, what's that?
We're throwing something up against the wall, see if it sticks.
Yeah.
You got a lot of interesting content out there.
Oh, I appreciate it.
And I think other people would like to listen to it, as well as read it, listen to what you got going on.
Yeah, when you said we could talk about kind of the news, that really made me a lot more comfortable because I felt, gosh, I don't have to be as authoritative as Jay here. I can just kind of, talk about what the other authorities are saying, so to speak.
Yeah.
So that helped a lot. I appreciate it.
Yeah, no problem. Hey, turn on your cam. Let's see you.
Oh, I don't have the cam on. I haven't used this much. Let me find out the.
Here. I'll.
Okay, I have video. I think I figured it out.
There you go.
Okay,
Boom,
you see?
good.
Great. Hey, awesome, man. Yeah, thanks.
So, Tony, Anthony, what do you want?
Anthony's good.
Anthony.
Yeah, that's how I grew up.
Anthony's preferred.
Yeah, man. And you're up in is it Michigan or Illinois or
Chicago area?
There you go. Okay.
Lived here 2-3 years.
Yeah, you had the simultaneous fast talking, but also I think you have a Midwest friendliness to you, so that's nice.
Well, it depends. It
can depend.
That's what we talk about,
But I do pick up interesting things from your questions to Jay about what can NFL athletes do. I saw that guy on Netflix, that quarterback who's doing
Kirk Cousins, yeah.
Kirk Cousins, was it? Yeah. And my boss actually mentioned he saw that. He was like, hey, this thing you like is on, because he's a football guy too. So.
Yeah. Well, there's a lot of stuff going on out there, and as you said, we got Jay Gunkelman, and he's got a fixed amount of time because everybody's on his calendar, to to get mentored, and then same with Dr. Marie.
Well,
and then you, as I said, you put little interesting blurbs out there, and I appreciate open mind, fresh thinking, don't worry about offending anybody. Just, hey man, this is what's out there. What do you think? And
yeah, people tell me I can be a little direct on Facebook. I tend to be a little more diplomatic in person, but
well, that's why we're on Zoom.
There you go. You're going to help me with my image. I was just reading a study like right before you called. Neuroscience News, it says the way that people represent themselves or are seen on Facebook is not a true representation. They said the multimedia, they said things like video and photo is more reflective. So you're helping me out here.
There's a market for everybody. It's just people want to consume information a certain way. Some people don't have an hour to like physically watch something, so you have to do it in bits and pieces, and that's kind of your segment here. I think we can put a bunch of we can focus on mental health, but we can focus on other things as well, because I have my thinking cap on.
I saw that. Yeah,
do some thinking on the show. But before we get to it, Anthony, what's your background?
Yeah, so I went to University of Florida and did business and political science, but really took to mental health in past years, and science has been a big interest for me. mainly because, you know, I had a problem I couldn't solve. And that's something that neurofeedback, only Jay and neurofeedback has been able to help me.
Yeah,
I
yeah.
can get into that. It's probably a problem a lot of people have trouble with sleep. Um, yeah. As far as work these days, though, I am a social media manager. So that's part of why you see me on there, but
Uh-huh.
in the health and fitness space. So nutrition, I work for a nutrition PhD, a kinesiology exercise science PhD candidate, and a couple of other brands. And um, yeah, I guess I'm researching things all day, either for one job or the other, and I'm
Right,
posting.
right.
So yeah.
So of your posts, I thought we could just get together and then you could just run down the things that you've, put out there and make
Yeah.
comments or, I'll say you're
Yeah.
full of it or I agree with it.
No, I'm happy to. And yeah, I just tried to pick up maybe some interesting stuff this week. I just wanted to say, like, the neurofeedback community on Facebook, I feel like it's actually pretty good. And there's some good groups on there. People like Jay are on there,
Mhm.
and people are like, "How do you know Jay?" It's like, man, if you are open on Facebook, you might get a response from him too.
Right.
Uh, and so I've been trying to share. There's a great Brainmaster has a great group, by the way, that I feel like everybody there are really interested in the brain. And the neurofeedback community that I discovered on there, helped me get into neurofeedback. I feel like there's some of the first people with answers. I was able to attend Jay's conference remotely, and just something as simple as like, uh, why are some people responding to psychiatric medication and some do not? They get no benefit, or it goes horribly wrong. And I feel like you guys, you had Martijn Arns, and he showed, they're just using the alpha frequency, someone's alpha frequency in their EEG, and they can tell you from there, what is the most likely treatment they're most likely to respond to. Is it ketamine? Is it
Mhm.
TMS, transcranial magnetic? These are things people need to know. And so I've been trying to relate all these things I'm picking up from you guys to the news. I'll give you one. Like last week, and I don't know if we want to screen share at some
Yeah,
point,
here,
but
let me turn it on for you.
yeah,
A good idea.
I got one right here. I don't know if you can see my screen right now. This study here, I don't know if I need to move that, but this one here, Autism and Beyond, Unveiling Overlapping Neurotypes. And in it, they say 72%, 76.2% of children with autistic traits also exhibited ADHD traits. And 55% met the criteria. This is a brand new study. This is January 15, 2024.
Uh-huh.
And if you've been listening to Jay at all, or many of the people in this community, neurofeedback people, EEG people have known this. And one of the reasons if I had to guess that Jay would point out is because both autism and ADHD, he loves to mention that they both share a feature which is called subclinical epileptic discharges. 50 to 60%, I think Jay says, of autistic sufferers have epileptic discharges. Subclinical meaning they may not be having seizures, but you can see it in the brain scan. And he likes to say, I think he says 30 to 50% of ADHD sufferers also have this. So we have psychiatrists that don't know this, and this is not something that neurologists are testing for. If they're not seeing a clear seizure, but these are so-called subclinical, it's the marker of a seizure. And as Jay says, it can manifest as anything. It can manifest as lapse of attention. It can manifest as behavioral issues. And so it's just, after listening to you guys, reading a bit, and I'm seeing these news stories, it's like, man, why did the academics, well, some of them did, because that's where Jay's
Yeah.
getting it from. Why is this such news to them, And why aren't we allowing this to change our treatment for these things? Why aren't we testing with neuroimaging, you know? So I get fired up at the same time, but I also try to inform people, and you can find answers to these questions is what's cool with the EEG. I have a friend who took her daughter in for ADHD like symptoms recently to the psychiatrist. and they gave her a stimulant medication. And before she did, she asked me, she said, do you think that's going to be a good idea? And I said, from listening to Jay, there's about a 30 to 50% chance that if she has these subclinical epileptic discharges, or if she has, I think he also calls them paroxysms in the paper, which are these sharp bursts of energy in the EEG, that medication may not work. And sure enough, the medication, it made her daughter, in her words, it gave her rage, and they had to take her off of it. And so they're now, I was kind of amazed. We now have a psychiatrist in our town here in Gainesville who does EEG. And so they're going to be able, I think, to see that. And, if I need to send them Jay's papers or something to help them select a medication, hopefully try neurofeedback treatment. So that was one of the first stories in the past week I thought would be a good one.
It's, I don't understand. You get a physical every year, you get a baseline of your heart and, weight, and
yeah,
we don't get a baseline of above the neck.
Yes.
I don't, because nobody's paying for it. They won't cover it.
We have, I was talking to an MD who I really respect, and he's actually started neurofeedback since meeting me. We're good friends, and he's getting fit. But I asked him why some of this isn't used, and I'm going to paraphrase him wrong, but thinks the effect of it isn't proven to the same degree that, say, use of medications is or whatever. And by that he means
more data.
More data. We need randomized clinical trials. He uses it, so he is open to it. But for doctors to recommend it, and actually he has, but for them to make it part of their best practices or their standards, they call it medical standards. We need more research. But you know what I looked up, and he would agree with this, I think. Most of the treatments doctors use do not have randomized clinical trials. There's a study out there that I can find. I forgot today, but I think they said maybe 40%. And most of them don't have these things called Cochrane reviews, which is like a very rigorous review. And I think my doctor friend would agree too. Do you really need a randomized clinical trial? I think he's even says something like this to tell you, take aspirin when you have a headache, or get a cast when you have a broken bone. And I think what he would say is, if the side effects are low enough, and if there's encouraging data, and if it's not too expensive, then go for it. And so he's doing it, and he's starting to tell his patients. So just because we can't, prove everything beyond the highest level of statistical significance doesn't mean people should be afraid to give us a try. And I personally have seen amazing transformations. So that's why I'm going to continue to recommend it, and hopefully we'll have that data.
Well, let's talk about Ozempic, man. Okay.
I love it.
That's more than just weight loss. I mean, that's cravings, addictions, and the anterior cingulate.
Exactly.
That hits the switch there. Who cares how the switch was flipped, right?
Yeah.
People need to know that's what it is. And here are the different things that you can do. Not one size fits all, but some people do the Ozempic and they lose their 5-6%, and that's all that they lose on it. And you hit a wall.
And there's side effects.
Side effects. But
I mean, that's almost how it works in a way, because it makes you nauseous. I mean, I've heard doctors describe it. But this is another thing. I think you said it on the podcast. You made the perfect comment. Something like, does Ozempic prove that obesity is something in the brain, or there's a related to the brain? And I think it absolutely does. Because, and neurofeedback people, I mean, Jay is always talking about reward sensitivity issues. Food is a reward. We're drawn to it. People with these issues are too drawn to it. Same with addiction. And that is why I think you guys mentioned people are reporting, and there's now case studies and formal studies showing that Ozempic is helping people with alcohol, with other drugs. And so that, to me, that's not an appetite issue. That's probably not their digestive system. This is hitting the brain, and clinicians are becoming more aware. I was tipped off to this when I said to myself, I've started to think of the EEG as, how can I understand better what a medication is doing that's either given to a friend or in the news? And if you look up Ozempic, you find out that it elevates, I believe, this is memory,
Yeah.
elevates theta waves. And if you hear Jay talking in Jay's
Mhm.
phenotype paper, this may not be true, perfectly true everywhere, but the theta waves are related to dopamine metabolism, and dopamine is a reward hormone. So the idea being, I think you're mentioning the anterior cingulate. That's this area where we're controlling our external focus. It's executive control. It's top-down control, inhibition, making decisions where we put our attention. That Ozempic is probably helping this area, just like neurofeedback can seem to help. And as Jay mentions, this anterior cingulate area is involved in addiction, but it's also involved in ADHD. And it may be, I think there may be one small study out there right now on eating disorders and things like that. So hopefully we can get out there one day, if we can clear the brain, as Jay says,
Yeah.
in
Yeah.
these areas like the anterior cingulate, we can help you not just with obesity, but like Ozempic, we can help you with potentially other temptations. And not only that, it'll be much lower side effect. You won't have to worry. My nutrition clients just did a podcast on Ozempic about a week ago or this week. And they said, like, man, this drug shows how badly people want to lose weight, because he has clients telling him, yeah, it makes me throw up once a week, and he says, for me, that's, I couldn't imagine, but he understands the desire to lose weight because he's had all the same issues in his life too. So,
It's just
uh,
the irony of it. It's okay, it's $1,600, insurance won't cover it, but they'll pay,
I love that.
tenfold a lot more for this other stuff. So
Yeah. People are paying like $1,000 a month for Ozempic. And you know what, as you mentioned, um, for some people, they don't get all the same weight loss. For some people, the side effects are much worse. And I'll tell you what else. It's likely, I posted one day. So the drug works primarily, the action is on this thing called the GLP-1 receptor in the brain. And the action there plateaus. Which is why you'll hear reports, it's a bit early, but you'll hear people saying, oh yeah, after a year or two, maybe my weight loss started to plateau and it gets slower. So conceivably, I was surprised I didn't see too many neurofeedback studies on eating yet, but if somebody out there wants to do it, I think it's, as Jay says, it's a sound theoretical basis. It's based on real science about how that anterior cingulate controls our attention, and where we get our rewards from. So I would love to see more data. Uh, and anecdotally, I'll tell you, believe it or not, I'm somebody who has always struggled with weight. Um, I lost weight a few years ago, but since I have done, I can't say for sure, it's anecdote.
yeah,
My weight has been extremely stable since I began neurofeedback. And I'm just one person, so take that for what
right,
it's
right,
worth.
right, right.
In my adult life, I don't think I've ever clustered around. I feel like I'm in the same 3 pounds for a couple years now. And that, I mean, put it this way, I was picked on for being a bigger kid, and even in college, I would get ribbed, and
Yeah.
so so all I can say, it's helped me.
Tell me who they are, I'll kick their butt. So
You're good. Okay, I needed you when I was growing up. There we go.
so digital Ozempic, digital
Yes, I
this,
loved
that,
it.
I think, we got a marketing issue, we got an insurance issue. Uh,
Mhm.
we have an end game issue. Nobody wants to have an end game on services, you know.
Neooh, will
Neurofeedback,
they not need us, or will
yeah,
we not need them rather?
yeah,
Yeah.
yeah. So come
You
on,
know,
guys.
yeah. In the nutrition industry, we talk about that. There's all these articles coming out. The topic of my clients' podcasts in the health and fitness industry is, is there a need for nutrition or health and fitness bloggers in a world of Ozempic? And I think there is, because, there are people who are not always going to want to use that, which is why they should come try out neurofeedback and get their reward sensitivity recalibrated.
Yeah.
Um, but also, even Walmart posted, or I think it was a comment on an earnings call, that they're seeing that their customers that have Ozempic prescriptions, because they have a pharmacy they can see,
Hmm.
those customers are already buying less food. And there was a New York Times article this past week, 2 days ago, I read, that they're wondering, is craving, the concept of craving, you can't have just one. Is that going to be effective marketing anymore in a world where people do not have uncontrollable cravings? But but maybe we could achieve that without the expensive drugs, and I would love to see that.
Well, technology got us into this problem. It's got to be able to get us
Mm.
out. Corn and sugar, and
Hmm.
that that
Yeah.
that had to have
Go
played a
on.
role. I'm not sure when the corn, when the government started subsidizing that, and it became more of the 60s, 70s. I don't know what it was, but I think that's when
Yeah.
things, went to crap. What else
You
you
know,
got on here for us, Anthony?
well, let's see here. I have a few studies. Uh-oh, it's got my little browser missing there. Um, yeah, so there was a little bit, oh, I wanted to talk about PTSD would be one.
Yeah, yeah.
This is a chart that I don't know. I think Mari has talked on this, talked with this about you guys. This chart is from Ruth Lanius, Dr. Ruth Lanius, who's a big MD researcher on PTSD, and she uses EEG and she uses neurofeedback. Another guest of yours, Sebern Fisher. I think Dr. Ruth may have been a
They,
guest,
they
but
were they, they were both on the show. Yep.
yeah, I love it. And this is an MRI from Dr. Lanius's studies on PTSD sufferers. And I thought it was relevant. I think it's a cool chart. What this is showing is the activity of a network called the DMN, the default mode network. They say right down here. And essentially what this says is um, these are normal people on the left, or normal but non-PTSD sufferers, and these are PTSD sufferers on the right. And if you notice, the DMN is the red stuff. If you notice, the DMN is weaker in the PTSD sufferers, is less active on that upper right corner at rest. So I thought this was important because a study came out the other day. Um, well, how to start with it. Basically, I don't know if you've ever noticed, but PTSD sufferers, I think they're even said to be more empathetic. It feels like people who have been through trauma are more sensitive to the trauma of others. And I guess the article I'm reacting to is a New York Times article and more that came across the other day called Powerful and Cold-Hearted. And what they found out is there's a lot of studies on this. When people gain power, they somehow, and they don't know precisely why, in several studies, they seem to be less sensitive to the needs and the pain of others. And there's an ERP study, which is a brainwave study that Jay likes, but this is just a quick study. They found that people that have power, when people were induced, so I forget how they induced them, but they made them feel powerful in the study, and then they showed them the actions of others. Those people, their brain showed no resonance or no reaction to the actions of others. Whereas participants who had felt powerless, they resonated with the actions of others quite a bit. And so why am I talking about this? So if empathy is related to the action of that DMN network I was just showing, one of the interesting things about psychedelics that everybody is using,
Hmm.
psychedelics also seem to deactivate this DMN network. They do other things as well, but that is one of the things. And you'll hear people say, I felt at one with the universe. The DMN, I forgot, I don't know if I mentioned, it's a seat of, or it's part of the sense of self. So a PTSD sufferer, and this is for clinicians out there who probably already know this, but anybody else maybe, that
Right.
PTSD sufferers sometimes are lacking that sense of self. But that for other people, maybe losing that sense of self in a psychedelic trip could be therapeutic. And so I just think that's really interesting, manipulating the sense of self. And a lot of times this is a focus for neurofeedback. So Dr. Lanius's treatment, and sorry if this is getting a little in the weeds, but her treatment, she often does alpha down at PZ, which is PZ is the parietal network, which is, I think I'm pointing to it here with my mouse here on the upper right. So
Yeah.
they're often manipulating the activity. Sometimes they'll do alpha up, but they'll manipulate the activity. And that's one of Sebern Fisher's favorite treatments for trauma. And Dr. Lanius has studies on alpha down at PZ, the parietal lobe. And they find, I mean, Sebern Fisher, if you read her book, I think I've heard her on your podcast, she's seen transformations in as little as one session because it's known as a very powerful treatment. So I'd love people to know about all sorts of neurofeedback. This is one too that we could help people all by manipulating the same way psychedelics do, but you don't have to have the bad trip with neurofeedback. And maybe in, according to Sebern Fisher, one session potentially. So pretty cool stuff, I thought.
Well, PTSD, what did it come out this past or last year? I mean, it's FDA said, hey, we acknowledge it. Thumbs up for PTSD. Ruth's up in Canada, and
Yes.
they have a little bit bigger budgets, but even in Canada and the
Okay.
U.S., all the vets are using it for PTSD. If it's good for the vets, why
Mhm.
isn't it more mainstream?
Yeah, I guess there's
If it's an end game.
so they're doing more research in this with vets. Oh yeah, veterans. Yeah, that is, and obviously I think a lot of people have heard of Body Keeps the Score, which is by Bessel van der Kolk, and that was the first MRI scans of trauma that I recall, and or that I believe they're the first ever. And he found a lot of very interesting things going on in their brain as well. Um, I also wanted to talk about, speaking of trauma, I wanted to talk about addiction. Why are these things like addiction, ADHD, obesity, what could be a reason that they're all correlated beyond they're happening in the same brain region? There was a Kaiser Permanente study. They found that trauma is a 4,600% risk factor for addiction. Actually, there it is, 4,600%. But anyway, I don't know if you can read that. Anyway, so people can get it. I'll show the name: childhood trauma and addiction, the 4,600% risk factor. And Jay has talked about phenotypes. Jay has his paper, and the phenotypes in the anterior cingulate that affect, so elevated alpha, theta, or beta there are related both to addiction and ADHD and even disordered eating. There's other phenotypes of these things too, like ones that are more anxiety related and things that have to do with arousal. But all these things seem to be related. And why would trauma do this? Well, trauma is not just an emotional injury. Early life trauma, as we know, this is old hat to I know a lot of your viewers, but it physically changes the brain. It damages the brain. It can cause things like inflammation that stay around, that the brain has trouble repairing. And it could be affecting people late into adulthood. Um, and this is not just neurofeedback people. There's an addiction MD. He's big on YouTube. His name's Howard Wetzman. And he was actually the first person to alert me to this relationship between addiction and ADHD and obesity. If you Google those three things, they're all correlated and they're all related to trauma. If you have trauma, you have a higher risk of all three. And he actually uses genetic testing to try to find out which phenotype you have and then tell him which drug you have. But I let him know about Jay's EEG studies and the phenotypes for ADHD, and he was actually fairly open to it. So I actually find that doctors can be open. Now, whether they have the solutions and whether they
Right.
have the information that we have. So I don't know what the answer is. I'm not a university researcher.
I'm
I
definitely
do
not
have,
Anthony, but when you go
yeah,
to the doctor's office and they give you that stupid clipboard and those 10 pieces of paper to fill out the history, why don't they just ask for the genome to spit in a tube, then come back?
yeah. This guy used to do that. He ran a genetics lab in his addiction treatment center. So he could try to pair you with the best drug.
Yeah.
But we have drug-free treatment for a lot of people, for most people. It seems to work. 80 neurofeedback seems to work for about 80% of people in a lot of different studies. And Jay has a famous study that he talks about a lot. They gave neurofeedback to school children that were diagnosed with Ritalin. And the neurofeedback, I have this study. There's actually a few studies that did similar. But anyway, this was a controlled trial. I think I don't know how you randomize that, but it was a controlled trial. And anyway, well, you can randomize it. You can't blind it. They know whether they got neurofeedback, I guess. But anyway, the children that received neurofeedback, they called it Ritalin-like effects in this paper. But not only that, and Jay has said this, but When the Ritalin stopped, their behavior improvement stopped. Their ADHD largely came back. When the neurofeedback people stopped, they showed an improvement symptoms a year out. And as Jay says, people are even reporting improvements above and beyond a year to 2 years out. And that's just where in this study they stopped measuring. Who knows? And as we know, a lot of clinicians know, come back to them 2 years, they'll probably be doing even better in certain areas. So it's pretty incredible the tool that we have. And it's crazy to me how many doctors I'll talk to and other people that they don't even know about it. Doctors don't even know the EEG. I have a close MD friend, and he says, yeah, like we only learn the EEG for seizures, for clinical seizures. Jay talks about white matter or something like that. He's like, that's not commonly used for that purpose to verify a dementia diagnosis. Maybe it is. He says, this is how rare EEG is in a doctor's world that I can tell. He says, he goes, I don't even know what the EEG doctors are called. Beyond there's neurologists, but the people who's particularly specialize in EEG, he says, in the hospital, we just call them the EEG fellows because I don't even know what they're called and there's so few of them. He says there's like 3 of them. So it's this underutilized tool. I could probably go on forever, but Jay talks about every study you open. I read every study every day. I mean, all the science news. They're all using MRI. Their EEG's growing, but their favorite is MRI. And Jay talks about, MRI is not great in the time resolution or time domain. It doesn't tell you when a particular part of our brain was active, for how long, what type of activity was there. So I have academic friends. I live in Gainesville, so I'm next to UF. I went to UF. They're all using MRI. I don't think anyone ever heard of some of the studies that Jay points out, like that if you put a salmon in an MRI, a dead salmon, it shows brain activity, and it's the other thing is there's a meta study out there that shows that MRI is not reproducible. It's something like they can create the same result. If they scan twice or do the same study twice, they get the same result, like maybe half the time. So, I do have a UF neurology friend. He is familiar with this. He doesn't use EEG yet or neuroimaging I don't think yet, but he's a pharmacy professor at UF and he is familiar. So anyway, we've got and our tool is cheaper. One thing I have heard, I will say, is the word used, the scans are futzy. You need a skilled practitioner to do this right. And there's training involved and there's labor involved. I don't know how much labor precisely is involved in MRI, but it seems to be you don't just want to go to anybody for no feedback. I always get them looped into somebody that you guys know or that Jay knows when people come to me asking. So I've had Jay telling me, do you know anybody in London? Do you know anybody in, California, obviously California and anywhere, Canada, because I find that, just because you go somewhere doesn't mean you're going to get a good reference EEG. You're going to get the best treatment. So yeah, a lot of work we need to do.
I'm not a neuro genius. I'm a overglorified video editor.
And I'm not yet.
But the TMS, when you're pointing that magnet, okay.
Yes.
Why wouldn't you do an EEG to find out where you want to point it versus messing around and have somebody wiggle their fingers, say, oh, that's the spot?
Yeah, I would love to know more about where they're at with neuroimaging. I guess Martin Arns is the researcher that seems to have, he had a great presentation at Jay's conference at Sassoon conference. But with regards to TMS, I think they said that the outcome is roughly similar if they're using that thing called the 5-inch rule or something, or the 5 centimeter rule. It's just a guideline, but we're probably going to find other places to use that magnet, so to speak. So I do want to see neuroimaging done. I just saw a study actually just yesterday of MRI guided TMS, and they claim that they improve the treatment. I don't know, did they say 15 to 30%, something like that? So there is improvement, but Arns is showing that. He shows you can get a better depression treatment if the psychiatrist just knows what your alpha peak frequency, like I said, And you can go from, I think he uses 20 to 30%. We hear about TMS a lot, right?
Yeah.
Arns's studies, the studies he shows are saying 20 to 30% efficacy. But I think that's it's either remission or response rate. But if you know the person's alpha peak frequency, you can raise that to 50 to 60%. I'll tell you what else. This is just an interesting anecdote for you. If anybody of your viewers are considering TMS, sleep is a huge issue in TMS. There's a study out there showing if you're not sleeping, your TMS will not work. And I first became alerted to this. So we have a Yale psychiatrist in town that I'm friends with, and he did an open house on this. And he was talking about how if you think of your neurons as these little trees, and cortisol released from stress can break the tree. Well, TMS, through releasing something called BDNF, can repair the tree. And they showed these mouse slides, and it's like a little shriveled tree. And then they give them a particular treatment. It might have been ketamine. That tree regrows. And so I said, gosh, well, and he says this happens during sleep, which is true for neurofeedback too, by the way. The learning from neurofeedback, it's happening truly during sleep. It's called synaptic plasticity or long-term potentiation. That happens during sleep. So I said, if that's happening during sleep, do your patients that don't sleep well get a worse outcome? And he said this. He said, that's a good question. He said, this is what I found. The studies that I was seeing on TMS, which we know that there's some dispute here, but he's saying I was seeing that I should be getting like an 80% response rate to TMS, but I was only seeing like a 50% in my patients. So then one day, and I couldn't figure out why, he said, one day one of my patients said to me, oh yeah, and I'm getting a sleep study. Or he said something like, I'm not sleeping. And they come down, you need a sleep study. So he says, now I started sending my patients to sleep studies before I do TMS, and my response rate doubled, or it went up to that 80%. Yeah. He says, now I will not even do TMS on you unless you get a sleep study. But again, we can bring this back to neurofeedback. Sleep is a, Nicky Whitridge, I think you had him on.
Yeah.
He just put up a video yesterday called, it's something like, it's not sick and tired and not going to take it. It was This Has to Stop was the name of the video. He's doing a video project on his journey to get better sleep. He started yesterday. I think he's already met with Jay, and he's having his EEG. This is the journey that brought me to neurofeedback, because I had tried everything for sleep. And I almost get angry nowadays. There's these sleep experts that come on podcasts that don't know EEG. And to me, if you don't know EEG, you don't know anything about sleep. Because first of all, that's how sleep studies are done. But more than that, we know about things like your SMR, your sensory motor rhythm. If it's not strong, if it doesn't fire, the sleep spindle fires and you get woken up too easily. But none of these sleep doctors know this. And so their advice to me, granted, this may work for 15% of people, 30%. Yeah. None of it has ever worked for me. I don't need a doctor to tell me, or a university researcher to tell me, oh, well, just put down your phone and you'll sleep. No, didn't work for me. Oh, just turn the light, get rid of blue light, put blackout curtains, take melatonin, take magnesium. I tried everything. And my MD friend, he said this to me one time. He said, we don't have good sleep medicine. That's a direct quote and what he means is all of the medications they can give you that work are habit forming. They're things like Ambien and benzodiazepines. Those work great, but their Ambien is called a Z drug, and they work in a similar fashion to benzos, which, as you know, are some of the most addictive and dangerous drugs. Ambien is addictive too, habit forming. And so he's like, I have nothing I can give you. That's not the one thing they can give you are histamine drugs. So they will give people essentially, they're called tricyclic antidepressants. They'll give people things like Seroquel and Remeron and Trazodone, which are very strong drugs. I think some of them are antipsychotics, some of them are antidepressant. But the main way they're putting you to sleep is through histamine. They're essentially a very strong antihistamine drug. And just like a Benadryl will make you sleepy, these are very strong Benadryl. And people report, I have friends that have tried these. It was the only way they could get sleep. They haven't tried neurofeedback yet, but it was the only way. They wake up, they feel dead. I mean, they're jet lagged the whole rest of the day. Or in the case of some of them, they cause major weight gain. So these drugs are not the best way. Meanwhile, we have SMR, SMR neurofeedback, as Jay talks about, it has been compared to so-called the doctor's gold standard. The best practice, the medical standards for a doctor for insomnia is something called CBTI. CBTI, cognitive behavioral therapy, insomnia. You essentially answer a bunch of questions and guided prompts to get you to, think about your sleep differently and to change your relationship to sleep. That is the doctor's gold standard. And why is it the gold standard? Because, like I said, the medications are habit forming and it seems to have some efficacy. But they compared that CBTI to SMR in 2 studies. I think one of them a meta study, and they found out that SMR worked better than CBTI. And not only did SMR neurofeedback work better than CBTI, SMR was the only thing that actually improved the physiological markers of sleep, the deep sleep brain waves that are when your body are regenerating. They said the only thing that CBTI did was improve your subjective appreciation of sleep. In other words, the guy was not sleeping any longer, okay? All that happened was he feels less bad about it. And I'm not going to say that's nothing, but we've got something that could actually enhance sleep. And when I did SMR, I'm actually still doing it. I was able to nap for the first time in 10 years. I used to be this guy who's up, once I'm up for, 18 hours, 16, whatever it was. And I can nap. I swear to you, I don't think I'd taken a nap in 10 years. So I'm eager to see, how Nicky's journey, and it's one of the first things I recommend now. So that's my whole sleep spiel that I was really hoping to say too.
I hear that on almost every show, especially with the kids and ADHD, that they're sleeping 2 hours less per night than they were 20, 30 years ago.
Mm-hmm.
Then you throw in, the sugar on top of it, and then you try to get them to go through neurofeedback, and it takes longer. It's not as efficient.
Yes,
Pa parents don't get that, and it's
exactly.
if you fix
If the,
anything, like you said, figure
Mhm.
out the sleep.
If the client is not sleeping or the patient, when is their brain having time to heal? That is when the learning, the synaptic plasticity, long-term potentiation is another term. That's when these neural pathways, they say what is it? Nerves that fire together, wire together. They're wiring together at night. And if you don't get that sleep, it doesn't it doesn't remain, it doesn't
Yeah.
solidify. So yeah, we need to get people more sleep.
Well, the stuff
If
that's
they can
making
learn
us
it.
go to sleep, again, I'm not an expert, but it's like a blunt instrument.
Yes,
It deadens everything, and the brain needs to do some work while you're sleeping, not just to be flatlined, right? So,
exactly. Um, you know, that's another thing. In a biological system, something is never just having one effect. We're too interlinked. We're too complex. And so you can't just give somebody a drug and only have the effect you desired. There's always going to be something different. And even that actually even applies to neurofeedback to some degree. I do know people that get side effects. They're usually things like short-term irritability or short-term, like the night of, sometimes people get worse sleep. But that actually tells you, in my opinion, that's actually probably a good thing because it means we're doing something. You know, the one thing a person with a side effect can't say is that we're not doing anything because, and the first time you experience something like that, good or bad from neurofeedback, it's like this eureka moment. You're like, wow, I am not just serotonin and dopamine. The medication model, we found out there's a big study this past year. None of this stuff may be operating through serotonin, but these brain waves, as an MD friend puts it, the brain waves are higher order. The serotonin and dopamine, those are not there. If you just have serotonin, that's the endpoint. You feel good. Dopamine and serotonin, they're messengers to get your brain to fire a certain way. And the brain waves are the representate or the total of how they're firing. And that was the eureka for me that got me into neurofeedback. I had heard about neurofeedback and I kind of filed it for sleep. I was looking how to solve this issue and I kind of filed it away. It seemed a little bit, a little woo-woo. I couldn't envision a mechanism of how can I just watch something or hear something and that changes my brain. Now it feels extremely obvious because that's almost just what your brain is. Your brain is always changing. Everything you do changes your brain. But anyway, I filed it away and I kind of ignored it until I saw a study a couple years ago it's an MIT study by Dr. Liwei Tsai. And it is a study on how simply hearing 40 hertz rhythms can change the brain of mice and clear them of brain plaques, such that those mice had the memories of young mice. When they put them in a maze, the mice could remember again after they're exposed to this. These doctors are now doing this at MIT and other schools. Again, Liwei Tsai, TSAI. You can look this up, 40 hertz stimuli. It works with light or sound. They're now doing it with humans. They recently showed, she has a study with humans earlier. I think it's like only 40 people. It's an early study. It cleared the inflammation in their brain was greatly reduced. And it caused, just by listening to these things, and it caused glial activity, which, as Jay talks about glial a lot, they're like the housekeepers of the brain. But when I heard that, I said, and it works through something they think called entrainment, where if your brain hears a rhythm of a certain kind, that affects your brain waves. And that for me was the trigger. For some reason, I was now willing to believe that neurofeedback could work. And I'm really glad for that reason that I came across that study. But that's what it took for me even to buy in.
Right.
But this stuff is going to reach mainstream. We're not there yet. We're kind of, I feel like we're starting to take off, and people take to it. I actually find they react. It probably depends maybe how strong you sell it. Everybody knows this is way better. But if you come at it as, this is something that changes your brain waves, which is almost more important than these chemical, I find they react better. And I think it's because people know, everybody knows someone, if it's not them even, they know someone who tried 3, 4, 5 antidepressants and it didn't work. The average, there's a study, I think the average person has to try 2.5 antidepressants to get symptom relief. And by the way, the meta studies on antidepressants, and Arns talks about this, they only work for half of people. So everybody, I think, has either been or they know someone that been that person that the medication did not work for. And they know there's got to be something else. There's something that explains that. And I think there's a willingness to at least entertain that it's these brainwaves. So very cool.
Anthony, I like what we got going on here. It's the first one. We're going to figure this thing out.
Yeah. Thank you.
Let's pump up your technology group on Facebook.
Please do.
What's it called?
I run a Science and Technology Discoveries. You can also just find me at Anthony Ramos. I'm going to try to make more of those posts public. Science and Technology Discoveries. And the other thing is, you can also check out the Brainmaster group. Neurofeedback Exchange is another Facebook group. There's several, if you like to be anonymous, there's several groups on Reddit. And let's just get especially clinicians in there and troubleshoot. And I'm learning things every day.
Yeah.
I'd love for people to join me on there.
Yeah, and I think what we're going to do is keep these hot topics going. Hopefully we can get our listeners and viewers to respond with comments and give us feedback. Life is all about feedback, whether it's neurofeedback, right? So
I like that.
Give us feedback so we can help people figure out that there's an end game to mental health. Anthony Ramos, thank you for coming on the NeuroNoodle.
Thanks so much, Pete. I appreciate it. We'll talk again.
The NeuroNoodle podcast is supported by listeners and businesses just like you.